Thank you. So I would be speaking on pharmaceutical interventions, and the basic introduction has already been covered. So, and we are expecting much more children going forward due to the increased exposure to digital screens in children, in spite of all our efforts to reduce it. So the most important molecule that is available to us is atropine, and as we all know, just a little bit of introduction. Atropine is a non-selective muscarinic antagonist that acts on M1 to M5 receptors and is distributed on almost all structures of the eye when it is applied. So there are various hypotheses of mechanism of atropine for prevention of myopia progression, or retarding of myopia progression will be a better term. One of it is the accommodative pathway. Initially, it was thought that atropine prevents the progression of myopia through its cycloplegic action exerted on the ciliary muscles and thereby causing changes in accommodation. But animal models demonstrated that atropine prevents myopia through non-accommodative mechanisms. So this didn't stand. Second is via the muscarinic retina receptor pathways in the retina, and these are found in the RPE layers, and atropine dampens vital function of retina and boosts dopamine release in cellular stores. So this is one of the theories for the mechanism of action. Another is rapid and transient choroidal thickening and uninhibited eye growth, in which it blocks the accommodation due to the choroidal thickening. And another is that it acts through the animal studies showed that synthesis of glycosamine glycan of the scleral extracellular matrix is inhibited by atropine. So these are some of the theories about it, and going with the history, how it came into being. So first in 1979, a study was conducted with using 1% atropine ointment, and control eye shows significant increase in rates of myopia as compared to the treated eye. And initial studies showed that atropine 1% or cyclopentolate 1% were effective in slowing progression of myopia, and that the effect of atropine was better than that of cyclopentolate. So this is where it all started. And then came the ATOM studies, and the ATOM 1 study was a parallel group placebo-controlled RCT and double mask study. It evaluated the efficacy of and safety of topical atropine in slowing the progression of myopia and ocular axial elongation. The participants of this study received 1% atropine once at night for 2 years. What they concluded was topical atropine was well tolerated and effective in slowing the progression of low and moderate myopia and ocular axial elongation in the population. But obviously, with 1% atropine, various side effects are associated. So this was not very practical. Then came the ATOM 2 study, in which three concentrations were used: 0.5, 0.1, and 0.01%. So this is the first study in which the present form of atropine that we use came into being. And what they concluded was that myopia progression reduced by 75, 60% with lower concentrations like 0.51, 0.1, and 0.01 respectively. And similar findings were noticed in axial elongation, but there was no observed effect in axial elongation in the 0.01 group. So they concluded that 0.01% atropine has minimal side effects compared to 0.1 and 0.5, and retains comparable efficacy in controlling myopia progression. So it was found to be safer than higher concentrations. In phase 2 of that study, atropine was stopped for 1 year and rebound was noted. So rebound was 24% in 0.01. So what they concluded was rebound myopia was least in 0.01%. And again, that worked in our favor because even the side effects were less in this group. So that is why, in conclusion, they showed that there was a clear rebound phenomena in terms of myopia progression that was dose dependent, and with 0.01% atropine, it was having least progression during the washout period. 0.01% atropine was more effective in reducing myopia progression after the washout period. So in phase 3 was the retreatment phase in children who had rebound progression, and the children exhibited the children who exhibited progression of 0.5 or more in that washout period, they were restarted with 0.01% atropine for further 2 years. And what they concluded was retreatment with atropine 0.01% was as effective as the primary treatment. So with the findings of these studies, we have the basic guidelines on how to treat these children. There was another study called LAMP study, and low concentration atropine for myopia progression. And what they did was they compared 0.05, 0.025, and 0.01 with over a period of 1 year. And what they concluded was all these three concentrations reduce myopia progression along a concentration dependent response. So higher concentration had a better response. All concentrations were well tolerated, but according to them, 0.05 was the most effective in controlling the spherical equivalent progression over a period of 1 year. Another study is once monthly dosage of atropine 1%. So in this, there were 660 participants, and once monthly atropine 1% for 2 years was spaced 15 days apart. So drop was given at one eye at a time. So suppose right eye is given on day 1, at 15 days, left eye was given applied. And one important finding of this was near vision blurring lasted for only 4.6 days after the application. So that was a positive finding, as we are more apprehensive that near vision will get affected for a longer period. And once in 2 months, atropine was given for 1 year. After the initial 2 years, the frequency was reduced to once in 2 months and no treatment in the final year. Dropout rate was 20% in the first month itself, but this study concluded that it improves atropine efficacy, retard moderate myopia, reduces atropine side effects, and minimize myopia rebound, and most importantly is the increased compliance with the drops. So to summarize, the low dose 0.01% for a period of 5 years, for up to 5 years, is a clinically viable treatment option for myopia retardation. Age group 6 to 12 years with documented myopia progression of 0.5 or more in the preceding year are suitable candidates for the treatment. Myopia between 1 to 6 diopters and astigmatism less than 1.5 diopters can be selected. Once daily nighttime dosage, and initial treatment should be continued for 2 years. So how long to continue the treatment? Suppose after the initial treatment, if there is a good response, that means a progression of 0.25 or less, and especially in older children more than 13 years, atropine can be stopped. If myopia increases in the washout period, then restart it. Moderate response, in which the progression was 0.25 to 0.75 in the second year, continue atropine till the progression slows down to 0.25 or less. And poor responses more than 0.75 in the second year, probably these are non-responders, so atropine can be stopped. Now, this is one of the important studies done by Dr. Rohit Saxena, and this compared the Indian population with the ATOM studies. And what they found out was a significant reduction of 54% in the spherical equivalent with 0.01 at 1 year in myopic children with no side effects. Axial length elongation was 21% less in the atropine group compared to the placebo group, but was not statistically significant. And these findings corroborate with the ATOM-2 and LAMP study, and rapid progression that has been noted in the atropine group in 18 to 28% of children with Chinese ethnicity In Indian children, it was not found. And some of the side effects, which all the 4 studies were compared. Ocular side effects, mainly photophobia. And in my patients, what I've noticed, this comes only with if you switch to twice dosage. In single night dosage, generally photophobia or blurring of near vision doesn't appear. And it appears in higher concentration. Local allergic response is very rare with atropine. Glaucoma induced by atropine incidence is as low as 1 in 20,000 treated patients. And systemic side effects of atropine is very uncommon. So to conclude, evidence supports low dose atropine to slow the progression of myopia. Motivation of parent and children is important for long-term compliance and adherence to treatment. Good eye care habits and enhancement of outdoor activity and limited near workload, or in present scenario, digital exposure of children, should be taken care of. Studies of non-Asian ethnic groups are required to determine the effect is as significant as is reported in Asian children. And rebound associated with all low dose atropine needs to be further studied to formulate guidelines for further treatment and discontinuation of the therapy. Thank you so much. And as sir had pointed out, we all should go with this guidelines on myopia, which was released by AIOS and was very helpful for all of us. Thank you so much.